All right. Well, good morning or afternoon, depending on where you are, everyone. This is Brandon Gare with our first NMQF webinar of 2021. We're at a new year. We have a lot more new things happening, including I'll start with the positive, including no matter what political affiliation you have, we had a large voter turnout in Georgia, and I had the opportunity to do a little voter turnout in Savannah. So I represent Savannah State today. And we're going to do a good talk on COVID-19 therapies that many in this audience may have heard of, but we want to just have a deeper discussion about it. And as always, we have two great panelists on the call, but I'm going to go ahead and let our very own Mia Keys do the introductions and take over. So Mia.
Brandon, it's great to be back with you and the NMQF family in 2021. Especially Happy New Year. Happy New Year in the sense that, we continue to press forward, and hopefully your families are safe and you are of high spirit and mind. I would be remiss if I didn't, of course, pay attention to the fact that we gather virtually, at the heels of a really very disruptive, but also galvanizing storm of events just this last week. And if nothing else, what it has done is really highlighted the need for consistent, concerted connection, deeper connections across all of our, not just our spheres of influence, but being in a space like this where we can dialogue and not necessarily agree on everything or come from the same place, but the exercise of empathy, the exercise of exchange of information, that's what we need to continuously fall back on, right? That really is the crux of democracy. And as much as possible, leaders like ourselves and people who are open to hearing what needs to be exchanged, that's the posture that we'll continuously take. The other thing is that's been interesting about this week is, especially given the events of the other night, it really overshadowed the ongoing crisis situation that we're in with respect to COVID-19, right? And the fact that we are over 360,000 lives lost to COVID-19, and we still have to stay vigilant. And so I'm very grateful that we're joined today by people who are able to help us to understand that vigilance and what it will take as we're now moving into a new phase where the crisis is ongoing, but now we have two FDA-approved vaccines, and so we want to talk to Dr. Nicolette Louissaint and Colonel Dr. Brian Burk about these therapies. And so, without further ado, I'm grateful that you all are joining us. Dr. Louissaint, you join us as the Executive Director of Healthcare Ready, and given your extensive background with respect to disaster preparedness, especially at the nexus of international concerns and epidemic or pandemic crises, we're grateful that you're able to bring your perspective today. And Colonel Burk, you're going to help also to bolster this conversation and talk to us about patient awareness and some of the things that a lot of our continuous audience members would be able to consider and take back into their own spheres. So thank you both for joining. And I'm going to turn it over to Dr. Louissaint, and maybe you can walk us through some really significant points, and then we'll turn it over to Dr. Burk, and then we'll have a bit of a conversation together.
Thank you so much, Mia, and thank you all for taking the time. Before I even go any further, I want to stop and acknowledge that, especially for those that I consider our partners in this response, time is truly so precious. So as Colonel Burk and I were even talking in the minutes before this, we were acknowledging that, for us, it's been 7 days a week for 13 months, many of us. And so I first want to start by just saying Happy New Year. I hope that you all are safe. I hope that your families are well. The thoughts of me and my team and the Board of Healthcare Ready are with you all. But I just acknowledge that taking an hour out of your time at any point in this response is significant. And I just hope that this is of value to you. I hope that we can be helpful and that we can answer questions that you all have. And so just first and foremost, thank you. To the NMQF family, great to be with you all again. Good to see your faces. Glad to know that you are doing well, and thank you for the important work that you continue to do. I'm going to just take a few minutes and very quickly first describe kind of why I'm talking to you, and then give a level set on what we see. And I'm really glad we're having a conversation about the therapeutics because as we know, yesterday we had 4,000 deaths in 24 hours. That is for me, 4,000 people who are connected to people whose lives were lost, whose families have been altered because we are still dealing with a pandemic. And so to me, that is of great significance. I am continuing to think of those families and lifting them up in my thoughts and prayers, recognizing that there are 4,000 people who are no longer with us just in the last 24 hours. And to us, that means something. And that is the reason that we continue to keep going 7 days a week for as long as it takes. So I am very honored to serve the role as the Executive Director of Healthcare Ready. Our organization is actually 15 years old this year. We were founded initially as a coalition shortly after Hurricane Katrina, and we were founded to serve as a public-private partnership. The recognition was that the private sector had the ability, especially across the supply chain, a part of the healthcare sector that most people don't talk about until they need something from it. The sector had the ability to do more than was asked during Katrina. And part of the reason that could not happen was because there weren't partnerships in place, mechanisms of coordination beyond just, procuring a contract. What can we do together? How do we approach responses together? And that's been our charge for the last 15 years, making sure that on all hazards, natural, what in emergency management we consider to be man-made, events, pandemics, disease outbreaks, we are working together. And, people always ask me, what does this mean? So this is just a brief snapshot of the different ways that we work. We work on making sure that deliveries of critically needed healthcare supplies can be made all the way through that critical last mile. It's great that it gets to the port. It's necessary that it gets to the facility. Hospitals are critical parts of a response, but if those hospitals don't have the supplies that they need, they're buildings. So we need to make sure that they have the supplies. We coordinate donations, we coordinate resource transfer, we provide access addresses access issues. But we also make sure that even not during times of what we call peace between events, that we're working on strengthening those partnerships, creating plans, and doing the work of making sure that we are stronger for the next disaster. So when I look at what happened last year now, it's important that we think about all of the things that really happened last year and what that means for our healthcare response. And I actually want to start with remembering that we had wildfires and hurricanes that were catastrophic. We had one of the most active hurricane season years we've seen in modern history. We also had an extremely severe wildfire season that left parts of the West Coast significantly altered. And so when we think about all of the ways that we approach this pandemic, it's important that we remember that other parts of our disaster infrastructure were altered as well, and that there were public health needs that came from those disasters that also had the backdrop of a pandemic. And so as we talk about a few things, there are going to be a few terms that may be familiar to some of you, but may not be to all of you. And so I just wanted to kind of lay out a background of where we are. So we have the pandemic. Secretary Azar, the HHS secretary, declared a public health emergency in January of last year. That has been extended. That's very critical for the resources that need to flow, the posture of the federal government. But often we hear, okay, there's a public health emergency, but what does that declaration mean? It is a mechanism that the federal government has. States have this authority as well to declare public health emergencies and declarations for their states. But it allows for, first and foremost, a recognition that the scale and scope of a disaster overwhelms a local jurisdiction's ability to manage that disaster. But by declaring a public health emergency, it opens up several types of resources that allow for the federal government to provide increased support to states and local jurisdictions, as well as tribes and territories, but also with flexibility and nimbleness that are needed to respond to the event. As a part of a public health emergency, for example, I think a few months ago, there was ample discussion about the role of pharmacists in disasters. And we as Healthcare Ready often believe that pharmacists and pharmacies are critical parts of disaster response. But under the public health emergency and as a part of these plans, pharmacists and the expanded scope of practice for pharmacists to be able to deliver care, administer vaccines have been a big part of this discussion. So I just wanted to first point out that we do have a public health emergency. Within that expansion of the authorities of the public health emergency, just a few examples of things that we'll see. We'll see unlocked funding from the federal government that is directly intended to support communities, support to businesses that are critical for healthcare response. Remembering that a lot of the healthcare sector is the private sector. This is important. The use of our military and our DoD partners to be able to provide technical guidance, logistics support, enhanced supply chain support. We can expedite things that are coming through ports, recognizing that there's a public health emergency. So if masks and gloves and gowns are coming through on a ship, they can get expedited out of a port. We can use the Defense Production Act to surge production of certain critical supplies. So there are many things that can be done, but I just wanted to make sure that I talked about the authorities that allow for the federal government to take these actions, because it's important to first start there as we think about the impacts to healthcare. And you know, this graphic on the bottom, it seems very obvious, but I want to explain why we are taking the time to talk about therapeutics when we know that there is a vaccine. As I mentioned, there are 4,000 people who lost their lives yesterday to this pandemic. And so while we are working on vaccinations, it's not just enough to have vaccines, they have to be administered. We have to be mindful that there is still an ongoing pandemic and that there are still individuals that are being infected and lives being lost. And to do our part, we have to think about both vaccines and therapeutics. So the idea of a vaccine is to prevent infection and disease progression. However, there are therapeutics that are available should someone become infected. And they're really right now two buckets, if you will, for that. We're thinking about positive diagnosis therapeutics that are available at the point of positive diagnosis. But as you'll see that little brown graphic here, if one is hospitalized and disease continues to progress, there are therapeutics and regimens that are now available to help to address the immune and inflammatory responses. I think the bulk of our conversation today is going to focus on those outpatient therapeutics, recognizing that at the point of diagnosis, there are therapeutics, monoclonal antibodies, that are designed to help your immune system to mount a response. So the idea is for those therapeutics, that delivery would be as soon after positive diagnosis as possible to avoid the progression of disease and avoid that immune and inflammatory response. But again, going back to the top point in this slide, avoiding hospitalization, avoiding further burden on ICU systems, because what we know is that our ICU systems and our hospitals are quite stretched right now. And so while we talk about where we are in vaccines, it's important to remember that the vaccination process is a long arc for us. As a part of pandemic preparedness plans, we've always known that the hardest part of ending a pandemic would be effective vaccination to get to what we would consider herd immunity, 70 to 90%, ideally closer to 90, being vaccinated. And we're dealing with a multi-dose vaccine, which means that we need to get a shot in an arm, not once, but twice. So as we're thinking about where we are with vaccines and the hard work that has to be done to get to herd immunity, we have to recognize that therapeutics are going to play a very critical part in not just protecting us, but also alleviating strain in the healthcare system. This is really intended to show a couple of things. All of these graphs make one simple point. That uptick is the current hospitalization or ICU burden. Hospitals are strained. This is the first time in my life, adult life, that I can really think of being able to communicate to people that there is no guarantee that if you go into a hospital system, that all of the resources that you would normally assume are there would be there to protect you. So avoiding hospitalization, avoiding further strain on hospitals, ICU systems, healthcare workers is very critical. And we have to remember that also, based on this data, we're looking at a situation where 1 in 10 Americans at least are living in an area where their ICU beds are either completely full or have fewer than 5 beds available. And one thing that we often think about from the healthcare ready perspective is that it's not just about the number of beds. Capacity is a lot more than just the number of beds. It's about the workforce, the supplies that they need. We often call it staff and stuff. But with that, it's really critical that we're thinking about all of the ways that we're playing a part in preventing the transmission and the progression of disease. And so with the emergency approval process, I wanted to take a second here because I think it's really important that we understand emergency use authorizations and that we work together to make sure that in our messaging and in our language about therapeutics, that we're explaining what an EUA is and it isn't. What we are saying is that there's an expedited review process that's in place, that there is continued review from the FDA, our regulatory authority, to make sure that safety and efficacy measures are met, and that the potential benefits of an approved product outweigh any known potential risks. And so that to us is very important to make sure that we're explaining, especially for our communities of color who have questions. And as we are working through public health language around how do you describe an EUA, it's important to make sure that we're describing the full pathway, that we're describing the rigor that goes into an EUA review, and that we're also talking about the focus on safety and efficacy that the EUA process actually hones in on. As we're talking about therapeutics, I'd be remiss if I did not mention the other part of the FDA lingo, which is the biologics license application. You will also hear the BLA process mentioned. Biologics are a subset of products or medical countermeasures that includes things like a monoclonal antibody cocktail or antitoxins or vaccines. And so I just wanted to point this out. I think it may come up with some of the questions, but for the products that we're discussing, they have both EUA approval and a BLA application filed. So the therapeutics that are currently available, you will see the first two are monoclonal antibody products that are designed for that outpatient part at the point of positive diagnosis. The eligibility criteria are here. I also want to mention that it's important that we look at how hard these companies worked in the trials to make sure that they had diverse participation. And so what I saw from the data is that between 7 and 10% of participants were Black or African American. Around 40 to 50%, depending on the study, were identified as Hispanic. We also saw the median age was somewhere around 45. So it's really important that we saw that. I think it's about 62% or so between the studies had at least one comorbidity. So the point of me saying this is these products have been studied in the populations that they're intended to support. And studies are continuing, and a lot of this data is being made available through peer-reviewed journals and available to the healthcare community. That's what informs these eligibility criteria. The monoclonal antibodies, because they are antibodies, are administered by IV infusion. And I will just quickly point to remdesivir, which is the antiviral that is a small molecule drug that is used in conjunction with either a steroid or a monoclonal antibody, would be used in a hospital setting at the point of disease progression. That remdesivir product with dexamethasone, baricitinib, are intended to address the immune and the inflammatory responses that the body may have in response to COVID. So that would not be appropriate until the point of hospitalization and disease progression. So I just want to point out that there are a few tools that are stood up and continuing to be improved every day to provide resources that allow for providers and patients to understand where therapies have been distributed and where infusion centers are located. And so the URLs are here. I'll also put them in the chat as we're talking, but just wanted to point out that there are tools that are being refreshed on an ongoing basis that make it possible for you to see where these products are available and where you may be able to go for to be able to access them. And then very quickly, I know cost is often discussed. What we know so far on monoclonal antibodies, the federal government has procured product, and that product is being pushed to healthcare providers. There is no cost associated with that product. Administration is being covered by the federal government, and there is a process to be able to submit a waiver with one's insurance plan. For uninsured patients, there's the ability to claim reimbursement, again, not for the product. The product is being covered at this point by the federal government, but for the administration through HRSA. And again, we'll make these available, but the billing and coding information, which people always ask me for, is available at that link at the bottom of the slide. Remdesivir had a similar pathway where the initial allotments were procured by the federal government, distributed by the federal government. And at this point, those initial allotments have been used. And so hospitals are using the private sector supply chain to procure, distribute, and manage the distribution, as well as the cost and reimbursement processes for remdesivir. So with that, I as we began this, I often think about Dr. Susan Moore's case, which I think is top of mind for many participants. My team has talked about her case, and frankly, as a person that is in the healthcare community, I find myself wondering if I could have personally done more, or if we as a community could have done more to support her as she battled COVID-19. And I think that to me is really what impressed the need for this slide, and really thinking about the fact that this effort to make sure that patients have this information, that providers have information on therapeutics, and that it is as easy and straightforward for anyone who is infected and needs this treatment to have it is really a burden on all of us. And so thinking about how we each at different parts of this healthcare community can play a role for tracking information, communicating that information, using the tools that are available to figure out in your zip code or near your zip code where product may be available, advocating for the need to make sure that that information is available in multiple languages at different literacy levels, and not just to providers, but also to patients, so that we're making sure that there is ample opportunity to avoid another day like the day that we saw yesterday with 4,000 deaths. And so with that, I'm happy to leave these resources and tools for you all to consider. And I thank you for the opportunity to provide this overview, and very excited to jump into the discussion.
Thank you so much for that, Dr. Louissaint. You gave us a lot to consider, and particularly your third to last slide was a perfect segue into what I'm hoping that Colonel Burk can help to elucidate for us. So Colonel Burk joins us from Operation Warp Speed. And so I'm wondering if you can foremost tell us about what that is, what Operation Warp Speed is, what you do there, and speak to us specifically to Dr. Louissaint's point about reaching patients where they are, speaking a language and using vernacular that's not, bulky, that's not aggressive or intimidating. What does your work look like with respect to that? And then talk to us about monoclonals as well, please.
Yes, ma'am. Thank you for this opportunity. That was a great presentation, and I want to kind of even mirror how she started off of talking about the partnerships. I will tell you, if anything good's come of a pandemic, which it's hard to imagine any silver lining, is the fact that this has been a global effort that's been mirrored nationally on trying to combat the effects of COVID across the globe. And Operation Warp Speed is one of those partnerships. It represents a partnership with the federal government, states, public health departments, pharmaceutical companies, all in an effort to basically come to a solution. I'm a physician assistant, And I'll tell you, for much of the last year, it's been hard to be in clinic when I've got somebody who I know is a high risk patient who basically is likely going to suffer more than most people. And all I could do was send them home with hope. And I think that is what has really come about from my perspective with the therapeutics that have come about out of this is there is good research. And I'll tell you, and that is one of the things that I think that that there's enough for the Federal Drug Administration to say, let's get this out there for emergency use authorization. But now we have another thing. We have the challenge now is to get the word out. I mean, as a clinician, seeing 20, 30 patients a day, I often didn't have time to go home and read about what the latest news, latest and greatest. And sometimes what prompted me to learn more maybe of a new therapy was a patient coming and saying, hey, I saw this, or I heard about this new therapy on whatever it might be. And that often prompted me. So I think there can be a two-way street with good communication with patients. So our efforts right now, Operation Warp Speed, specifically is my lane, is I'm working with the therapeutics, but specifically the monoclonal antibodies, because our goal is to keep people out of the hospital. I would much rather people convalesce at home where they've got where they have the comforts at home versus having to get hospitalized. I think the most heartbreaking side for myself is watching patients who are hospitalized suffer alone by themselves with nothing but our medical staff by their side because their family members couldn't be there with them. And so that's what really, for myself, is what I'm excited about with the monoclonals, is it provides the opportunity to hopefully keep the person out of the hospital. And this is incredibly important for the high risk patients who have the greatest propensity to possibly succumb and die from COVID, specifically when you look at things like over 65 or certain medical conditions. So I think that's good. I think with what we're looking at right now with the monoclonals is we're definitely trying to get awareness out. We've had our directors talk with the American Diabetes Association, a very high risk population, and we've also had the American AARP, the retirement community. Our director has spoke with them. And so that's kind of what we're looking for is stuff like this. This is a great webinar that really shared the background of how we got to where we are today. And I think from here, it takes just that communication with our communities. It's I think one of the best things I've heard is the conversation starts at the community level between the patient and the provider. And I think this is what we're hoping for today. So I'm going to pause for any questions and turn it back over to Mia. Thank you very much for the opportunity to talk.
You used the word hope twice in your spiel, and I'm so grateful that you have. That is certainly something that we're holding on to, and we're also counting on the science. They are not mutually exclusive, right? They both live here. I want to get to some of the questions from the audience, but I also want to present a question to the audience, and then I think that will be helpful in directing some of your subsequent conversation. So to the audience, I want to know, and this is a poll question: do you feel like you know enough about the therapeutics such that you can consider them for yourselves or for family, for loved ones, for colleagues? Go ahead and submit that. And then in just a couple of moments, we'll have the takeaway from that. But in the meantime, let's just back up a little bit, because earlier, Nicolette, you were talking about, you were making the distinction between the vaccine or the vaccines as well as the therapeutics. And then Colonel Burk, you expounded on that. Tell us again, what's the main difference that people need to take away with considering, and you've mentioned it, but I think it bears acknowledging again, what's the main difference between having the vaccine or and considering therapeutics?
Sure. I'm happy to take this one. So the vaccine is intended to give immune protection against COVID-19. It is not 100%, but with 2 doses, it is better than a 92%, I think, across the 2 of them, protection against COVID-19. So that is the difference. The therapeutics are intended to provide support to your immune system, support to your body as it fights infection. So one is solely a preventative measure, One is the vaccine being a solely preventative measure. The therapeutic is if one is to be infected, the medicines that would be associated with helping you to fight the virus. Easy way to think about this, the flu. So if we were not talking about vaccine and we were talking about the flu, we all hopefully get our flu vaccines every year. Should you be infected with the flu because you didn't get your vaccine, or you got your vaccine and you were infected with the flu, the medicines that you would be prescribed to alleviate your symptoms and to help your body while fighting the flu to not have as severe a reaction to help you heal faster and recover, that would be a therapeutic. I hope that helps.
I think that clarifies it from the audience. There was an extended question. Once one receives the therapeutic, will you need the vaccine later on, or what's the exchange between the two?
Yes, so everyone's getting vaccinated. To get us to that 90%, everyone's getting vaccinated. If you have been infected with COVID-19, with SARS-CoV-2, the virus, and you have COVID-19, the therapeutic is available to help your body fight the infection. However, the goal is for all of us to be vaccinated. So as we're working towards that herd immunity and having, all of the globe vaccinated against COVID, they're not interchangeable. If you have the therapeutic, that doesn't prevent you from being eligible or from needing to receive the vaccine. If you are vaccinated, if you have the therapeutic and you have survived COVID, you still should be considering getting vaccinated.
And to be very clear, having the vaccine and having the therapeutic does not mean you cannot still potentially spread COVID-19 if we are not using proper public health protections.
If you don't mind, that's a great point, because I think that from a healthcare provider's perspective, even after getting the monoclonals, a lot of patients report feeling better. And that often in their mind, hey, I'm cured, and it's not. And that's something very important to emphasize is they need to, even though we give them the monoclonals and the intent is to convalesce at home, they're still infectious to their family members and people. So that it's not to come visit me while I'm at home convalescing. They are still infectious. So I think that's a very important point to emphasize.
And I want to, let's stay with that, Colonel Burk. I want to, before we extend on the point that you're making, let's bring the audience poll results back up and see where people are. So it looks like most people, almost 65%, are saying they don't yet feel like they have enough information about therapeutics such to recommend it. So we're really glad then that you all are on the call, that you're present, and we're hopeful that at the end of today's conversation, you may feel a bit more confident. So I'm wondering if actually, Keiko, if there's some way we could ask the poll again at the end of the session, that might be useful. And then also, of course, continue to spread this information. This is the good spread. This is the good stuff you can spread to some folk after the end of the call. So Colonel Burk, I want to go back to you. And then also, Dr. Louissaint, you might have something to say about this as well, because you laid it out so beautifully in your presentation. So talk to us about what exactly does the monoclonal do? How does it work? What are the physics of it? We know that it's mentioned that these are antibodies that are infused, taken through infusion. Talk to us about all of that.
The clinical pharmacologist in me is happy to do that. So I could probably go on too long. Just stop me if I do. So every compound, every medical countermeasure drug, medical product has what's called a mechanism of action. That is how it is effective, whether it's aspirin or if it's, a vaccine or a monoclonal antibody. It's important to remember that our bodies naturally produce antibodies. And so when we think about how does this outside compound work, let's first think about how the ones that we naturally produce work. So the ones that we produce in our own immune system allow for us to recognize a pathogen, recognize something from outside of our bodies to be able to say, hey, we've seen this and we know what to do when we see it. Target, destroy. And so, if you were a kid like me, eating dirt and all sorts of other stuff when we were outside getting into mess, we always joke that we have vigorous immune systems. Those immune systems are because we've now produced enough antibodies that allow for our body to know when we see something from the outside that is harmful to us, our bodies know what to do. Those antibodies will go, they'll bind to that pathogen, that thing from the outside, they'll neutralize it, and they will help it to be destroyed. And so when we're thinking about what the monoclonal antibodies do, it's the same principle. They are helping our immune system to recognize the SARS-CoV-2 virus as foreign and helping our immune system to recognize it, neutralize it, and then destroy. So it's helping to mount that immune response that your body needs to be able to produce to help your body to fight off that infection.
Yeah, I'd even like to add that on that same concept, when the new virus enters the body, it starts replicating itself right away. And it takes a time for it to replicate a large volume. It just keeps making duplicates over and over. That's an important consideration when you think about the timing of the therapeutics, especially with the monoclonals. The earlier we can get to the front end of it, when you've first been infected or first become symptomatic, the better the outcome. We know that for sure. That's why the emergency use authorization says after 10 days, it's really not shown to be as effective. And so therefore, that's why the limit has been put to 10 days. Because at one point after 10 days, the body starts responding to it with inflammation, which again, the monoclonals are just trying to fight the virus. The monoclonals prevent the virus from infecting new cells in the body, and therefore it can't make more copies of itself. So it's intended to stop. But that's why after 10 days, the body continues to respond. And that's oftentimes when the next therapies have to come in. And you'll typically see some of the other ones that are intended to manage the body's response. So hope that helps.
No, very vivid from both of you. And, and to summarize, and this is, and this segues into a question that one of the audience members had in advance of the conversation. Antibodies help to fight off inflammation. Inflammation is disease state, right? And to some extent, we all have some sort of inflammation in us at any given point of time, whether or not it then just develops into something problematic has to do, to your point, about our body's ability to respond in a timely and efficient fashion, right? And so, and with the nutrients that we're giving ourselves, or based on whatever we're exposed to, right? From a biological level to a social level too, right? Because we talk about social determinants of health and how that impacts us at the biological level. I want to talk a little bit about then vitamin D, and because a lot of people have questions about, and there's research coming out now that says that, or that has demonstrated that many of those who have succumbed, particularly African Americans who have succumbed to COVID-19, they've also been vitamin D deficient, right? So what do you say to people who are curious and considering therapeutics, but they're also receiving information about vitamin D and deficiencies? How can people help? How can this conversation help to streamline some of the questions that people might have about both of those?
I'm happy to start, Colonel Burk. So I would say that, and it's been about 2 weeks since I've looked at the last report on vitamin D. I would say that where I struggle is that most people are vitamin D deficient. And so part of the reason that I've been tracking this, but also really looking at the numbers and trying to understand the data, is because most patients are vitamin D deficient. So I think as long as you are following your prescribed just overall wellness plan from your PCP, many people with that, especially in times like 2020, where we're mostly indoors, not getting sun, not doing those normal things of going outside, having natural exposure to and being able to absorb vitamin D, probably need to take a supplement. But I do not think that these things are separate. I don't think that this is an either or, and we should be very careful to communicate that as well. You can both make sure that you are consuming, healthy foods, taking supplements, making sure that your consumption of vitamin D and iron and calcium, which are also challenges in our communities, are appropriate. Also recognizing that should you be infected with COVID-19, the monoclonal antibody therapeutic may be a very smart option for you as well. So I don't think it's an either or, but it's also important to remember with a lot of those studies that most of us are vitamin D deficient.
Very useful takeaway. Looks like Colonel Burke, you have something to add to that.
Oh no, I was absolutely going to agree with what she's saying. I think, and I certainly don't want anybody to perceive billing it as it's a way to prevent, any of the necessarily comorbidities or COVID in any manner. As she's, I've been seeing for years vitamin D deficiency, and the research is phenomenal. It's not just limited to COVID, but I think as we see more about it, I think we're going to be learning even more about the impact of vitamin D on our overall health. So I concur with what she was saying. Thank you.
Yeah, thank you both for that. And so let's go back to I'm so glad that you made the clarifying point that we're not necessarily talking about prevention, but we are talking about high associations, right? And one of the things that you mentioned, Dr. Louissaint, about hospital utilization, right? Right now, we're seeing in across all kinds of hospital systems within the U.S., especially though I will highlight on the West Coast. The Los Angeles area is seeing tremendous just impact of what's happening now with respect to COVID. And we have hospitals that are triaging those who are not necessarily expected to make it. And there's rationing, and this is not hyperbolic, there's rationing of resources like oxygen and so on and so forth. So I'm wondering, how can we think about the role of therapeutics, and this is also to go off of a question from the audience, in the reduction of ICU utilization, and then Colonel Burk, if you can speak to how then we can help patients to really understand, not to scare them away from hospitals, but to understand their own symptoms and where they are, and to stay home as opposed to come in.
Sure. One of the most important parts to me of where we are when we think about our healthcare system is the fact that what we know for year over year is that every year there are a certain number of strokes that happen in this country. There are a certain number of heart attacks that occur. There's a range, but it's pretty, we have data over time that shows that for a country that doesn't always take care of ourselves the way that we should, there are a certain amount of those cases that happen every year. And what we've seen is that fewer of those cases are going into hospitals today than they have if you look at historical data a year or two prior. And what that's telling me is that it's not that there are fewer of those acute care needs, it's that people are not seeking care. Why does that connect to this conversation? Because a big part of what also is happening from our healthcare partners, and thank you for all that you're doing, is that they're reminding people that if you have those symptoms, if you have those needs, it's important to continue to come to the hospital. And so we are in this point of, for many facilities, what they're calling crisis standards of care, recognizing that it is impossible with the level of the healthcare workforce that we're dealing with. Remember that, it's not just about, buildings, it's staff, it's stuff, it's supplies, it's medicines. Healthcare workforces going through extreme shortages, whether it's because healthcare workers themselves have been infected, needing a day off to, deal with their own immune response to the vaccine, which is totally normal, having to take care of their own family and loved ones. And then it's about available space. It's about available supplies. We've heard many talks about PPE availability. All of these things come together to create a burden on the system that's been persistent for the last year. So why am I saying all of this to answer your question? Because the goal is to reduce how far the disease is progressing, to ensure that we are not seeing exacerbation of disease or worsening of COVID-19 disease progression that would lead to the need to be in a hospital, or seeing further disease progression that would lead to the need to have ICU hospitalization. So the goal is, how do we make sure that we can first and foremost have a testing system that allows us to test people and quickly and accurately diagnose disease, make sure that therapeutics, the monoclonal antibodies, are available to them within those first few days where they're shown to be most effective, so that they are not seeing that disease progression and they're able to isolate at home, take care of themselves at home with telehealth or other supports from physicians that are able to care for them virtually, before they are seeing disease progression. So again, the goal is to be able to avoid that disease progression, because the other thing that we know is that COVID-19 can be survivable if we're able to do those interventions early. So again, trying to avoid that progression that would lead to hospitalization, ICU stays, and then ultimately higher rates of mortality associated with that prolonged disease progression.
Yeah, that was very clear. So then, Colonel Burk, what then do you say? What does a conversation sound like with the patient?
I concur with Dr. Louissaint. That was phenomenal layout of the challenges. It definitely starts with, as with anything, the whole relationship with patient provider depends on trust. And it starts off by the healthcare provider having a little bit more awareness of what's available. We can't predict which patients are going to be hospitalized or not, but if we know based off of the patient's history that they're a high risk, I think that's absolutely the first thing we start with, and just simply discuss that, hey, you're in a high risk category. And I think I'm a numbers type of person. I like sharing that, like, for instance, the over 65 group is only about 14% of the total COVID positive patients. However, they represent 80% of the deaths so far to date. And I think sometimes putting that, not a scare tactic, but actually just awareness that that certain populations, the high risk of patient is at a higher risk of succumbing to hospitalization and possibly even the disease in the end. So I think it starts with kind of the provider actually getting a better handle of what's available.
So would you say then that most patients or most people will learn about therapeutics first and foremost from their providers?
My personal as I mentioned earlier, one of the things I think that works the best, and thank you, Dr. Keys, for the question, is I think one of the things that works two ways. Oftentimes, providers, we hear like the NIH. The NIH did not necessarily go for or against the monoclonals, for instance, and so sometimes that can often, send off a negative signal that often, okay, well, I shouldn't use it, and that's not necessarily is not necessarily what they were intending. They're just saying right now they're staying neutral. And I think that becomes the point where it stalks with the patient. So oftentimes when the patient opens the discussion, that forces it. So if a provider is like, I'm just not comfortable doing it, sometimes a patient can open that conversation, say, hey, I've heard this works, or I've heard it's, some either family members or even some high visibility celebrities have received the monoclonals and they want to know more about it. And says, well, that's a powerful thing to start that conversation. So I think it is a two-way street, not just necessarily the provider has to start it, but I think we should be very open to the patient.
Dr. Louissaint, did you have something to add before I ask that question? Not sure if I cut you off.
No, you're good. I am thankful for the opportunity, but I think Dr. Burk covered it well. Thank you.
I think you laid that out really well. I bring that up because I'm so grateful that you mentioned really the role of influencers, right? And in a way, whether or not we're celebrities, all of us do have a sphere of influence where we can spread the word, where if nothing else, we can ask deeper questions and encourage people to seek out credible information from persons such as yourselves. And so I'm wondering then though, can we speak a bit to, because a lot of the information that we take in has everything to do with our social networks, right? So if our social networks are not necessarily tapped into these places of credibility or deeper awareness, then there will be a differential exchange of information or just a slower diffusion of true information, right? So what do we say to those real life impediments? What are some things that all of us on the call can be doing to ensure that the people we come in contact with, or even some of our softer ties and associates, can really benefit from what we know to be the case, what the science says?
I'm happy to start with this because I will be honest and say, after responding for 13 months, I am tired. And what I've realized has been the
Yes.
first thing, and and I think if we're all being honest, the first thing that goes is that extra communication, right? And so at the beginning, I was working really hard to make sure that, in addition to everything that I was doing within Healthcare Ready, I was calling my pastor and saying, I want to make sure you're thinking about the blah, 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 blah. I was calling my parents and, having family calls and trying to do that. Now I've taken a different approach because I simply can't do it. And honestly, some of the questions that I'm getting from loved ones and in my community are questions that I want to answer. But they're rooted in historical questions. They're rooted in historical trauma and mistrust that I do not trust myself to have the patience to answer as thoughtfully as I would normally. And so what I've tried to do is dispatch sentinels. I've made sure that I've explained everything I can to my parents, who I will be honest and say my parents have been able to identify for me more sources of misinformation than I think any tool could have ever done. And they'll send me things and they say, I get this on WhatsApp, what do I say to this? And I've worked on making sure that I'm explaining things to them who can then push back when they're getting those things. I've explained things to other partners, even some of my friends in STEM who are looking around and saying, we want to do more, how do we help? It's easy to have that 30-minute conversation and then charge them with having more conversations, whether it's on social media or with loved ones, but then also just doing the simple work of making sure that when you're seeing promotions for events like this, sharing it. So you're not necessarily just taking on additional burden and responsibility, but making sure that you're able to share information with those that you can and then charging them with doing the same, but also pushing out events that are like this so that people understand, okay, there's an opportunity for me to tune in on Facebook or log into this Zoom and have some questions answered and get issues addressed.
So grateful that you mentioned that. Dr. Burk, were you wanting to expound?
I was just wanting to share an anecdotal experience that we had. Our team was talking yesterday about getting the word out, and one of our team members is from Bolivia, and was sharing the fact that, like in Bolivia, the social media of reaching out, hey, my mom's O positive, we need convalescent plasma, can anybody help? That had been a powerful tool to get people to quickly come in and donate. And I mean, so again, you have like this pocket community, which is showing the power of within a community of social media. So I think we can't underscore the power and capability to really reach out well beyond ourselves. So.
Absolutely, and it is important to give voice to the burnout that is associated with doing such deep critical work within finite spaces of time, right? Because everything is an emergency right now. And Dr. Louissaint, you've worked at the juncture of emergency preparedness and disasters for years, right? And not for 4 years, for many years,
for
right?
Many years, yes.
Right, for many years. And the crux of Operation Warp Speed is also really ongoing and consistently urgent, right? So it's, of course, the warriors are going to be tired. And so, yeah, I love the fact that you use the terminology sentinels. And it's not lost upon me that we're using warfare related language, right? This is absolutely a fight of the fights, and it won't be the last time, and so I kind of, my next question really speaks to that, knowing what we know right now at the confluence of all these things that you mentioned earlier in your presentation with the Hurricane Katrina dating back, I can't believe that's 15 years ago, but you're right. I graduated from college almost around that. Yeah, I was a sophomore at that time. And I remember distinctly what was going on. And who would have known that 15 years from now, we'd be looking back at that for best practices or for things that definitely could have gone much better and applying it to our conversation around COVID-19. So I want to know 15 years from now, how do we close that gap so that we're not completely at a loss and off of our, caught unawares with respect to addressing these issues of global grave import?
Certainly. I often look at the graphs that show us just kind of the catastrophic events that have happened over time. For those of us that can remember the Oklahoma City bombing, we remember that walking into a secured building was never quite the same after that. Similarly, our 9/11 really shaped how we viewed emergency management and the role of national security and homeland defense. So I think I use those examples, but I could also talk about Hurricane Sandy, really showing us that first and foremost, hurricanes are not a Louisiana, Texas, Alabama, Mississippi, Florida issue. It can happen in coastal areas, and New York City is no exception. I think what's important to remember is that with all of these events, we have gotten incrementally better, but every time there's a gap, we forget. And that forgetting results in not just, okay, we just let our emergency management plan go or we deprioritize it. It also comes to the hard work of deciding where budgets are allocated, whether it's the federal budget or a facilities budget. We allow for us to really ramp up and say, this is really critical during an event. And then we forget and we don't do the work in between to make sure that we're really building preparedness. When I look over the last 15 years, I think we are better at how we do certain things, but we have a long way to go in how we do others. So when I think about 15 years from now, my hope is that COVID isn't such a distant memory as Katrina has been, that we haven't continued to build on that momentum to say, how do we build a view of response that is community-wide? How do we make sure that we're thinking about being prepared even between catastrophic events? And to me, that's what I'm seeing now, but also all the way to investments and the role of leadership and the role of, the federal government in a response and being able to say we need a warp speed because we need to move at warp speed. Like, how do we make sure that those things are not forgotten? I always like to remind people, this is an emergency management stat, but it takes about 30 years to respond, to recover from a catastrophic event. So even though we think about Katrina and say, oh, that was so long ago, we've gotten beyond that. If you take that number, that 30 years, in 15 years, we would have recovered from Hurricane Katrina. That also means that at any point in time, any part of the nation is still in some state of recovery from a disaster. So I think it's also important for us to frame in our minds from that perspective of thinking about what that means. And you talk about social determinants. What does that mean on a medical level? But what does that mean on a socio-ecological level? That we are constantly in some state of recovery.
So humbling, for sure. I feel like between the three of us and the conversation happening in the chat, we can go on and on and on. So I'm going to ask Brandon and Keiko to make sure that we have you two back, maybe in the mid-year, because I think by then we'll have additional. Thank you. We'll have additional information. Right? Certainly about the therapeutics and how they're rolling out. We'll have additional conversation to talk about access and how things are vying with respect to all communities having equitable access to what's needed. But with 2 minutes left, I just want to open it up to the two of you to offer any final takeaways for the time being to the audience.
Okay, I'm happy to start.
You're such a gentleman.
Yes, thank you, Colonel Burk. I just want to first thank you all again. Thank you for providing this forum to have a very important conversation. Thank you for your moderation of such an important topic, Mia. I appreciate you all. Thank you all for taking the time to participate in this. This really, I hope, is the beginning of a conversation. If there are ways that we can be useful, please do not hesitate to reach out. I think what we all take from this is that there's a lot of work to do. And what we take from the 4,000 deaths in the last 24 hours means we cannot stop. We do not have the luxury of letting up anytime soon. So if there is anything that we need to do to make sure that information is shared and that we are able to really make a meaningful impact and that we do not see another day like the day we saw yesterday, please let us know. We are eager and ready to assist.
And thank you all. That was fantastic. And I definitely, one last thing is we will be opening a website I'd like to share. It's combatcovid.hhs.gov. We're going to be relaunching it this weekend, and it's going to be set up for provider and patient education. And it'll link to the therapeutic site at HHS. and also provide some downloadables that either providers or patients can actually look. We're having a step download PDF, which will kind of, this is how I talk to my provider, and also some for the with statistics for the providers.
We love statistics. We love it all. So once again, thank you so very much, Dr. Nicolette Louissaint, who joins us from Healthcare Ready as their executive director, and for Colonel Dr. Brian Burk from Operation Warp Speed. Thank you so much for what you brought. We weren't able to get to all of the audience questions today, but really quickly, Dr. Burk, can you repeat the address for people, where people can go, the email, or excuse me, the website?
Yes, I'll put it in the chat also, but it's combatcovid.hhs.gov.
Great, thank you. And we again, we hope that you will join us again. And on behalf of the team, I will speak on behalf of the team from NMQF. I'm really grateful that you joined us. Thank you to the audience again. And once again, I'm Mia Keys. I'm with the American Medical Association Center for Health Equity. Always a pleasure to join these conversations. Let's keep them moving into the next weeks, and we'll see you again soon. Brandon, I'll turn it over to you, sir.
All right. Okay. Nah, thanks so much. I think this is a really good conversation and a way to start the year. We know what we have to do. We have these two experts here. We have Mia. And at NMQF, we love the data. So any stats and whatnot you can give. One thing, there were a few questions, and there were a lot of folks that asked us to reshare information. So when we send the video out again, we'll make sure that we put the links in it so you have access to it. So please check that. And then also we'll put contact information for the site for Healthcare Ready as well. You can find that, and then, as mentioned, Colonel Burke's site. So really appreciate your time. We look forward to seeing you again next week. And thanks again. Have a good, happy New Year.